Hello, good evening, friends. I'm Dr. Aarti Shahade. I'm the moderator for the 9th webinar that is being conducted by the DFSI. Thank you, DFSI, for making us the part of this wonderful series. Today, we have Dr. Prem Narayanan to tell us about managing diabetes in patients we encounter every day while treating diabetic foot. Diabetes, of course, is not only important, managing diabetes is not only important from the point of view of prevention, but hyperglycemia and increasing HbA1c have also been found to be risk factors for non-healing or delayed healing of the wounds. So, metabolic control in such patients is of paramount importance. It can be pretty tricky and challenging as these patients mostly have many comorbidities because diabetic foot itself is present because of various macro and microvascular problems. So how do we go about it and how do we treat these patients, especially when they happen to be critical or pre-operatively, post-operatively when they can be fasting, etc., are dealt by Dr. Prem Narayanan today. Dr. Prem Narayanan is an endocrinologist. He is trained in endocrinology in BHU and then he has moved on to Amrita. He did a stint there as an assistant professor and presently he holds the position of head of department in Ahilya Diabetes Hospital in Palakkad. So, welcome Dr. Prem Narayanan, and it's all for you.
Yeah.
Thank you.
Thank you, Dr. Aarti, for the kind words of introduction, and nice to meet you again. And last time we met in DFSI Coimbatore, you had shared my session on neuropathy. And again, thanks to Dr. Arun Bal and Dr. Rajesh Keshavan for inviting me to deliver this lecture. And DFSI is always in my heart, and diabetic foot is one of my major areas of interest. And so, as said, today's topic is managing diabetes in patients with diabetic foot or the foot attack. So, the agenda for today is briefly we'll see diabetes and diabetic foot, the relation, effect of uncontrolled glycemia on the diabetic foot outcome, just a ball rolling case, hypoglycemia and effects on the outcome, in-hospital glycemic targets from the various guidelines or societies, briefly about the various insulin types available, glucose management in critically ill, glucose management in the non-critical setting, and perioperative care with a take-home message. So, as you all know, diabetes, if you give it an inch, and definitely it will take a foot of you. So, some of the rules, the foot ulcers in diabetes, the rule of 15 is 15% of diabetic patients can develop foot ulcer in the lifetime. 15% of foot ulcers can lead on to osteomyelitis, and 15% of foot ulcers can end up in amputations. And the tragic rule of 50 for amputations is that 50% of amputations are maybe at the AK, that is above knee, or the below knee level, so which can be terribly disabling for our patients. 50% of patients can have a second amputation in less than 5 years' time, very important. And 50% of patients can die in less than 5 years, mostly from the coronary artery disease or from the cerebrovascular disease. So, it's a tragic rule of 50. So, diabetic foot, when you see, apart from the foot attack or the foot problem, the patient can have renal problem or the CKD, chronic kidney disease, maybe dialysis. Then, liver, another major organ, it can get affected in the form of non-alcoholic steatohepatitis, CLD or the chronic liver disease, ending up with cirrhosis. Then, as with the foot, there can be infection and even leading on to sepsis. Then the cardiac, you can see there can be coronary artery disease or even the heart failure, congestive heart failure with the preserved or even the reduced ejection fraction. Then stress, very important in the diabetic foot patients. There can be emotional and financial stress also. Then there can be peripheral arterial disease and also other there is a CV or the cerebrovascular disease. and other microvascular complications, that's retinopathy. So it will be a, you can see here how many things are surrounding a patient with diabetic foot. So just to start rolling, a case that we can see in our practice, a 52-year-old male, diabetic for 15 years, he has presented with the complaints of pain, redness, swelling and fever of the right dorsum and chin, and features are suggestive of an early necrotizing fasciitis. And he has a history of chronic liver disease with a ending up in cirrhosis, ethanol related, and it was child C. Case details, back in A1C was 10.7 and there is a creatinine of 2.1, maybe an AKE on CKD. Then you can see the deranged LFT, you can see the elevated bilirubin, low albumin, so size of cirrhosis 1.9 only, INR of 2.3, there is a coagulopathy, and luckily the heart ejection fraction was 60%, or it was okay. So you can see here the patient with necrotizing fasciitis with the two major organs involved. You can see here there is a kidney and the liver, and he also had retinopathy. So with this in mind, we move on. So in patients with stress or admissions, there can be absolute or relative insulin deficiency and increased counter-regulatory hormones. So this insulin deficiency or the relative insulin deficiency or the insulin resistance can lead on to increased lipolysis, so leading up increased free fatty acid levels in the circulation, and glycerol. So glycerol again, reaching the liver, it increases the glucose output from the liver, or the hepatic glucose production will be increased. Again, due to the insulin deficiency or resistance, there can be increased glycogen breakdown. Then again, because of the insulin related deficiency or action, you can see the muscle protein can break down, the muscle glucose utilization comes down, muscle protein break down, the amino acids again leads the liver, resulting in increased glucose output. So you can see here how hyperglycemia occurs. Apart from this, in diabetic patients, especially with food patients, the other glucose sources can be, you can see here IV dextrose, they may be on dextrose strips. Glucocorticoids, yes, stress, cortisol, or even in such as we use steroids, or catecholamine release, yes. Then inflammatory cytokine release, especially the TNF alpha, the interleukin 1, the major pro-inflammatory cytokines. Then the patient may be on parenteral nutrition, or the patient may be on enteral nutrition. So this all adds up to the hyperglycemia, which you can see here can have circulatory and electrolyte effect like the acid-base disturbances, the electrolyte disturbances, volume depletion, hypoperfusion, or at the tissue level you can see multiple effects can happen with reduced nitric oxide, platelet activation, immune dysregulation, all putting up, resulting in sepsis with a multi-organ failure and leading on to death. So just briefly about some of the clinical profiles. So this is from the data from Amrita. The clinical profile of diabetic foot in type 2 diabetes mellitus tertiary center experience. It was data collected from one of our BSc diabetes students. We analyzed around 413 patients, and the mean duration of diabetes was, you can see here, 15.5%, 7 years. Mean age was, you can see here, around 63 years, and the mean A1C was 9.49 plus or minus around 5%. So it is an unpublished data. Work is pending. Then clinical profile of diabetic foot infections in South India, again from Chennai. So now we have first we have seen what is the situation from the Kerala state. Then the next we move on to the Chennai. You can see a data which had 374 patients, which showed that the mean A1C was 10.2 plus or minus 1.6%. So you can see, and even the diabetes duration was around 11 years. Again, another data you can see here, this one again from the Karnataka side, is the Mangalore. Again, clinical profile of 120 patients showing that the mean A1C is 10.3 plus or minus 2.3%. So you can see here the uncontrolled glycemia is one of the inevitable or one of the crux part in patients presenting with the diabetic foot syndrome. So uncontrolled glycemia can affect the healing of the wound in diabetes. You can see the uncontrolled glycemia can lead to increased advanced glycation product, or as we call the AGEs, which can induce a pro-inflammatory cytokine TNF and IL-1, increase reactive oxygen species resulting in vascular and immune dysfunction, and it also can affect the collagen synthesis, which is important for wound healing. And also there can be changes in the cellular morphology, decreased proliferation, and abnormal differentiation of keratinocytes. So all these put together will delay the process of the wound healing. Then the IDE in wound fluid and healing. You can see here increased activity of insulin degrading enzyme activity in the wound fluid. There was one paper published in JCM in 2004, which showed that wound fluid had increased activity of insulin dependent enzyme, and the IDE activity in wound fluid was found to be positively correlated with the A1C level. So when the IDE activity increases, the uncontrolled glycemia of the A1C level also increases. So this again you can see here as the A1C increases, the ID activity increases, and again this was a small study, only around 13 to 15 patients only it was. And the amputation also you can see here when the ID or the A1C level increased, the ID increased, and the patients have more risk for amputation. So that is another important point. Then the relationship between A1C value and healing time for lower extremity ulcer in individuals with diabetes. So this was again published in 2009 a paper with a 63 patients of 63 ulcers. You can see here only 36 healed, and you can see here the red one in this graph is those with A1C between 4 to 7, and this violet one is those with A1C 7 to 10, and yellow one is those with A1C more than 10.1. So we can see around 66% of patients with A1C between 4 to 7%, the wound had healed within the first 84 days itself. And as A1C level increased, the wound healing process also took much more time. As you can see here, more than 168 days with A1C more than 10.1. And also another good thing was that this is I said the A1C with a 7 to 10, good proper care of the those with high A1C presenting to the hospital. If good care is given with overall metabolic and also the wound care, we can achieve the wound healing even within the earlier period, that is within the first 84 days. So that was the one good sign that we that is shown in the study. Then another meta-analysis, again, it was published in the International Wound Journal. It was a Chinese paper, but we looked into the A1C and the LE, or the lower extremity amputation risk in patients with diabetes, a meta-analysis. You can see here in this meta-analysis indicates that high level of A1C is an important risk factor for lower extremity amputation in patients with diabetes. So again, that shows the importance of a high A1C. Again, another paper from South Korea which showed that the risk factor for major amputation in hospitalized diabetic foot patients, you can see here, apart from the usual other causes of bone invasion, dialysis, and low hemoglobin, you can see here increased fasting plasma glucose is also an important independent risk factor for amputations. So that again focuses the importance of glycemic control in getting the wound healed. So now, right till now we have been looking at the part of hyperglycemia, but another coin, the other side of the coin is a hypoglycemia. This was a paper published in November 2009 in the JCM, the Association of Inpatient Glucose Measurement with amputation in patients hospitalized with acute diabetic foot. So this study looked into the effect of hypo and glucose variability with the amputation in hospitalized patients. Around 49 patients and nearly 46,000 glucose measurements were taken. You can see here hypoglycemia and severe hypoglycemia. You can see here it was statistically it was significant. You can see 2.66 and 2.9 odds ratio. There's an increased risk for amputation. So that is one very, very important factor. Also, hyperglycemia to an extent, the odds ratio was 1.75, and severe hyperglycemia 1.26, but it was not, p-value was not significant. So that shows the importance of avoiding a hypoglycemia in patients with a hospital setting. Then other glycemic indices, you can see hyperglycemia versus no hyperglycemia, it was significant, and the in-hospital mortality was under. In-hospital mortality was not significant, but hyperglycemia prolonged the length of hospitalization stay. Then severe hyper, no severe hyper, again it was not significant mortality, but the hospital length stay definitely increases. Hypoglycemia, yes, again you can see here it increased hospital stay. Then severe hypoglycemia, no severe hypoglycemia also increases the risk of hospital stay, and the variability or the high coefficient of variation that also increases the risk of hospital stay and even mortality. So a balance between the hyperglycemia and hypoglycemia is key in managing patients with a diabetic foot syndrome. Now, the definition of hyperglycemia in hospital setting from the ADI, it is defined as a blood glucose level more than 140 milligram per deciliter, and A1C more than 6.5% is considered to be diabetes mellitus in the patient preceding the hospitalization itself. Now, definition, that is hypoglycemia. Level 1 hypoglycemia is glucose concentration of 54 to 70, or those less than 70. Level 2 is a blood glucose less than 54, which is typically the threshold for neuroglycopenic symptoms. And level 3 is any level of biochemical value characterized by altered mental and or physical functioning that requires assistance from another person for recovery. So these are the ADA suggested levels of hypoglycemia. ADA recommends, so when caring for hospitalized patient with diabetes, consult with a specialist diabetes or glucose management team whenever possible. And it also shows that in the cross-section, comparison rate of both hyper and hypoglycemia were reduced by 30 to 40% when it is managed by a specialist team. Now, next we move on to the glycemic target, which is suggested from the various societies. So first, the apex body or the ADA and the ACE, you can see ICU setting, initiate insulin therapy for persistent hyperglycemia, that is glucose more than 180. Definitely you will have to start the insulin therapy. And the treatment goal for most patients is the target is between, to keep the blood sugar between 140 to 180. Non-ICU setting, no specific guidelines. If treated with insulin, pre-meal target should be less than 140 and the random glucose should be less than 180. More stringent targets if the patient was previously tightly controlled at the home. If it was previously tightly controlled, more stringent targets can be adopted. If the patient has multiple comorbidities or severe comorbidities as in our patient, then less stringent targets may be given. Then next, another important guideline for the Endo Society, they did comment on the ICU setting, but they given guidance on the non-ICU setting. Pre-meal target less than 140 and random as said less than 180. Glucose less than 180 to 200 is appropriate in patients with a terminal illness or those with a limited life expectancy or those at high risk for hypoglycemia. Then American College of Physicians, they give again the target for the ICU setting, recommends against intensive insulin therapy in patients with or without diabetes in surgical or medical ICU. And the target glucose to be kept between 140 to 200 is from the ACP guideline. And then finally, the Critical Care Society guidelines said that when the blood glucose is more than 50, that should trigger the response for insulin therapy. And to maintain the glucose less than 150, and also if the patient has a high risk of hypoglycemia, then the target can be eased out to keep it less than 180. And then this is another important study, or the NICE sugar study it was named. So it looked into the intensive versus conventional glycemic control. Nearly 6,000 patients were enrolled, multi-center, non-blinded, parallel group randomized controlled trial with intensive group to keep the target between 81 and 108, and the conventional group to keep the target between 140 and 180. So the result showed that there were no significant benefit in keeping into tight target, but the 90-day mortality was higher with the intensive group. So that is one very important point. So 90-day mortality was higher with intensive group, and the frequency of hypoglycemia in the intensive arm was 6.8 compared to the 0.5% in the other arm. So those with hypoglycemia also had two-fold increase in the mortality compared to patients without hypoglycemia. So that is very important study, that is NICE sugar study. Now next we move on to the glucose lowering strategies in hospitalized patients. So first, critically ill setting, always you start with a continuous intravenous insulin infusion, and it should be titrated according to the glycemic fluctuation and the insulin dose. Non-critical setting, the patient is having poor oral intake or the patient is nil per oral, then basal insulin shall be started with correction boluses. We will be coming into detail about the correction boluses and all. So this is a grade A recommendation of area. The patient is having good nutrition intake, so then we should start a basal insulin. Then the patient should have prandial insulin to cover the meal, and also correction bolus doses. Correction doses should also be given. So this is again a grade A recommendation from ADA. And use of only sliding scale is strongly discouraged. Previously, there was a pattern called sliding scale used to be used. We'll be coming in about that also next. So just briefly about the various insulins that are available for our patients. So the bolus insulin can be recombinant human insulin or the human insulins or insulin analogs. Basal insulins, again, there is first generation and second generation basal insulin. There are again analogs, and the premix insulin. Bolus insulin or the usual recombinant human insulin, the regular insulin or the short-acting insulin, onset of action is 30 to 45 minutes. Peak reaches by 2 to 4 hours, and the total duration of action is 4 to 8 hours. Again, the next category of bolus insulin is the analogues that we call, or the synthetic or the rapid acting bolus insulins, which is comes under the name that is aspart, lispro, and glulicin. The advantage is a faster onset of action in 10 to 20 minutes, peak action at 30 to 90 minutes, and the total duration is less compared to the human insulin, that is, it is only 3 to 5 hours. Again, now the bolus insulin, the other category which has come into our practice is a ultra fast acting bolus insulin. So which is already launched and available and used by us is a fast acting insulin aspart, that is under the trade name of PASP. And recently concluded ADA also had one newer molecule, that is a insulin lispro AABC. It is under the trade name of Lium-J, which is the latest FDA approved ultra fast acting insulin lispro. So onset of action for the PASP, it is less than 5 minutes. Peak action is 30 to 90 minutes. Duration is 3 to 5 years, but slightly it will be less compared with the usual aspart. Then next is the intermediate acting basal insulin, or the old warrior that we can put in. That's a neutral protein H1 or the NPH insulin. The NPH, you can see here, there is an onset of action at 1 to 2 hours, and there is a peak action at 4 to 8 hours, and the total duration varies from 12 to 20 hours, and it can be given once or even twice daily. Then the long-acting basal insulin, Detimel, again the first generation, onset at 1 to 2 hours, peak action at 6 to 10 hours, and the duration varies from 16 to 24 hours. Glargine, the onset is 60 to 120 minutes. No pronounced peak, even though, but a slight peak is said to be there at around 6 hours or 6 to 8. The duration of action approximately it is 24 hours, not full 24 hours, approximately 24 hours. Then we have the ultra long acting basal insulin category, which is comes under the name of Degludec and the Glargine 300. Onset of action by around 1 to 2 hours, no pronounced peak, and the duration of action can vary up to go up to 72 hours. Next, we again move on back to the critically ill patients. How to manage them? We have said that they need IV insulin infusion. So there are various IV insulin protocols that are available and practiced in emergency units, like the Yale, Markowitz, Leuven, Portland, and various names are there. Commonly used one is a Yale protocol is the one that is used. So the ideal infusion IV insulin protocol, it should be easy, effective, a simple algorithm which can be followed, safe with a reduced risk of hypoglycemia. Then it can be executed even by the nursing staff in response to a single physician order. So next we will be briefly look into the Yale protocol. Here, so as said, start IV insulin therapy in critical patients when glucose is more than 180. IV therapy should be given with a short-acting regular insulin, preferably using an insulin infusion pump. It should be diluted in such a way that 1 unit regular insulin is there in 1 cc of 0.9% of the normal saline. It is recommended to start insulin infusion, but you can see roughly you can divide the blood sugar value available, divide by 100 to get the blood glucose, to get the starting dose of insulin units per hour. Of the nearest decimal, we will be again coming detail. And Yale protocol had suggested to give a bolus dose. That, say for example, if the blood glucose is 350 and you divide it by 100, it's 3.5. Yale protocol suggested to give a bolus dose, 3.5 units as bolus dosage, and then followed by infusion. But recent concept is that bolus insulin is not recommended. So you can see here again with the various values of the blood sugar, you can divide it by 100 and round it off to the nearest decimal whole number, and you can start with the particular dosage as infusion. Then the monitoring of blood glucose. So the blood glucose should be monitored hourly until there is stable values are reached. Stable values means the previous 3 consecutive values are within the range, that is between 140 to 180. Then check the blood glucose. If it has reached the stable range, then check blood glucose 2 hourly. And if again check only 4 hourly monitoring is required if there is no change in the clinical condition and there is no change in the nutrition status of the patient. Change in infusion rate. You can see here. So if the blood glucose goes below 50, discontinue the insulin infusion. Give 1 ampule of D50 if available, or 25D amounting to 25 grams of dextrose as IV. Recheck the blood sugar after 15 minutes. And when the blood sugar has reached more than 100, wait for 1 hour, and restart at 50% of the original rate. So that at the time of blood glucose of less than 50, if the original rate was say it was 2, when you restart, it should be at 1 unit per hour. Then again, if the blood glucose is between 50 to 74, and the patient is symptomatic or in like in ICU setting, it is unable to assess the patient, give 1 ampule of 25 gram D50, recheck after 15 minutes. Then if the patient is asymptomatic, then give half ampule, only 12.5 grams of dextrose IV. And again, when the blood glucose is more than 100, wait for 1 hour and restart at 50% of the original rate. Again, next is when the blood glucose is more than 75. You can see here it has been divided into 4 categories: 75 to 99, 100 to 139, 140 to 199, and blood glucose more than 200. So you can, when you will have to check the blood sugar at the point when you will have to see which column you are coming into, and you have 5 rows also depending on the reduction in blood glucose per hour. Accordingly, the instruction column you will have to see whether it is increase infusion by 2 delta or infusion by delta, no change. That again, I will be coming up with an example. So you can see here per hour you will have to calculate. So say for example, the blood glucose was 250 when you check now, and you have checked the blood glucose after 2 hours, and it came down. It was came down to 200. So the reduction was 250 to 200. It was 50 in 2 hours. So 1 hour the reduction will be 25 milligram per deciliter per hour. Again, so which row we will have to choose it, and then you will have to look into the instruction column. And so again, from the instruction column, you will have to look into the current rate. You will have to look into the which is the current rate, and then if it is delta, then you will have to add up the delta or reduce the delta, or it is 2 delta, then you will have to add or reduce the 2 delta. Just for an example, so for example, for 54-year-old male, diabetic with sepsis, and the RBS is 485. So as we have seen, 485 divided by 100 is 4.85, rounding it off to 5. So you can start with 5 units per hour. 1 hour later, the RBS came down to 390. So the fall is from 485 to 390. So the fall is 95 milligram per deciliter. So you can see here, so we'll have to, the present blood glucose is 390. So we'll have to see the column, it is more than 200. So this is our column, that is the last column. And the fall is 95. So we can see here blood glucose fall between 76 to 100. You will have to decrease the infusion by delta. So our present rate, you can see here it was 5. So this will come to the category of 3 to 6. Again, so we'll have to reduce it by delta. Delta means 1. So we'll have to decrease the infusion rate by 1 unit per hour. So from 5 units per hour, the new rate will be 4 units per hour. So this is how critically ill patients will be managed with the protocol. And once the patient is has improved better and is going to start taking feeds orally, and you are transitioning from the infusion to subcutaneous, a dose of subcutaneous basal insulin should be given 2 to 4 hours before the intravenous infusion is discontinued. Then transitioning intravenous to subcutaneous insulin. For inpatients with hyperglycemia, transitioning from IV to subcu insulin and taking oral diet, initiate subcutaneous intermediate or long-acting insulin at 50% of the total dose as a basal component. So as the routine practice only, we'll have to calculate the per day dosage, how much the patient was receiving, and 50% should be given as a basal, and the rest of 50% should be divided as a prandial, and supplemental insulin or the correction doses will be added as required. Then again, for inpatients with hyperglycemia, transitioning from IV to subcutaneous, but not on oral diet. That is, we are transitioning from IV to subcu, but the patient has not started the oral diet. So in that case, initiate subcutaneous intermediate long-acting insulin at 80% of the total calculated dosage. So say for example, the total requirement was 40. So 80% of that will be given as a straight away as a basal, and prandial and supplemental insulin can be given as required. Next, we move on to from critically to non-critically ill patients glucose management. First, importantly, is a medical nutrition therapy. So, MNT should be included as one of the component of the glycemic management in hospitalized patients with hyperglycemia. And also, the diet should be planned in such a way that the consistent amount of carbohydrate shall be provided at each meal, which can be useful in coordinating the doses of the rapid acting to carbohydrate ingestion. Next, transition from home to hospital. So usually, the patient was on OAD, and with the diabetic foot or even sepsis, the patient is shifted to hospital. So, in that case, insulin therapy is the preferred choice. Discontinue OAD in acute illness, and those on insulin, those has to be monitored. That is, pre-admission itself, they were on insulin. So, if the patient was on premix insulin, on admission, uncontrolled glycemia, the patient should be shifted to basal bolus. If the patient was already on basal bolus, then the regimen or the doses should be intensified. Next, insulin initiation in characteristics. So we can those non-critically ill patients or even those not requiring admission also, or those requiring admission. So based on ulcer phenotype, so if there is deep tissue involvement, bone, tendon, joint, and all, definitely insulin should be started. If there is inflammation more than 2 centimeters around the wound, yes, definitely it is required. The patient is having gangrene or ecchymosis, petachias, history of coagulopathy or sepsis, definitely insulin. Or if there is any presence of foreign body, definitely insulin should be considered. Then depending on ulcer behavior, those acute onset ulcer, always consider insulin as therapy. Or the ulcer is rapidly progressive, again insulin. And those ulcers, chronic ulcers, not or chronic ulcers not responding to treatment, refractory treatment also, insulin should be considered. Then those with arterial venous insufficiency or even lymphedema, it should be considered. Those patients with electrolyte disorder, septicemia, DKIS, definitely will be going for insulin only. And again, even the multi-drug resistant organism, always consider like the MRSA, VRSA, definitely insulin should be the treatment of choice. Next, we'll move on to the basal bolus regimen initiation. So the total dose shall be calculated. It varies from 0.2 to 0.5 unit per kilogram. So depending on the patient characteristic, or we can decide on the starting dose. So it should be those who are elderly, more than 70 years, or those who are having EGFR less than 60, there is a CKD even 60. 0.2 to 0.3 unit per kilogram should be the starting initial dose. Those who are not meeting the above criteria and the blood glucose is between 140 to 200, even we can start with the 0.4 unit per kilogram body weight of total dosage. And the not meeting the above criteria and the glucose is 200 to 400 or above, then you should definitely start with a higher dosage, that is 0.5 unit per kilogram of body weight per day. And again, as said, it should be divided at 50% into the basal and 50% into the bolus or the nutritional insulin. Basal insulin, glargine or detrimer once daily. Detrimer or NPH, if you are starting, even you can start with once daily, and if required, you can make it into twice daily also. But make sure that it is given at the same time each day. And prandial insulin in 3 equally divided doses before each meal. Total dose adjustment, you will have to reevaluate based on the previous 24-hour glycemia. Any glucose more than 180, and there is no risk of hypoglycemia, other values, you can increase the total dosage by from the previous day's dosage by 10 to 20% you can increase. Consistently, the glucose values are above 180 or 200, you can even consider increasing the total dose by what I am putting. You can increase the total dose by 30%. And the patient develops any hypoglycemia, documented value less than 70, should come down the total dosage by 20%. Next, we move on to the sliding scale versus the supplemental or the correction scale. Sliding scale, here it was used previously in hospital settings. A set amount of insulin will be administered for hyperglycemia without regard to the timing of the food. Say for it will be categorized to various categories like 120 to 140, 140 to 180, more than 200. So like that, fixed values plus 2, plus 4, plus 6, or like that. And it is with without regard to the time of the food. Presence or absence of pre-existing insulin administration is not considered. Patient sensitivity to insulin, that is also not considered. And it treats another most important disadvantage with the sliding scale was that it treats a hyperglycemia that has already occurred. When you are seeing a value of 250, it has already occurred. So you are treating the already occurred hyperglycemic value, so the benefit comes on. So sliding scale presently is not recommended in hospital management. Correction scale. So what is correction? Correction dose is given together with the usual dose of the bolus insulin for the blood glucose above the target range. Say for example, the prandial dosage was 6 units. Then the correction calculator comes out as 4 units. So that 4 will be added to the correction dosage, the prandial dosage of 6, and 10 units will be delivered. Will be coming again definitely. And the correction scale, and the advantage is that it considers the insulin sensitivity of the patient comorbidities, and also the nutrition status of the patient also taken into the consideration. And it also corrects the hyperglycemia. It also negates hyperglycemia that is going to happen. So that is a supplemental insulin. You can see here various categories. You can see 3 categories: insulin sensitive, usual, and insulin resistant. So if the blood glucose more than 140 to 180 is sensitive, means 2 units will be the supplemental dosage. And if it is usual, it will be 4, and insulin resistant, 6 units will be added to the, I am telling you again, to the prandial dosage, which is already calculated from the total daily dosage. So like this, you can see 3 categories are there, and depending on the blood glucose values, which are pre-meal values that you are getting, you will have to add this to the prandial dosages. So the patient is taking all meals, you will have to follow the usual column. You can see here, patient is taking all meals, you will have to follow the usual column. This one will be the supplemental scale. Patient not taking meals, elderly, or those having renal dysfunction, so we'll follow the sensitive column. You can see here is the insulin sensitive column. So you can see here the dosage or the supplemental dosage will be much reduced compared to the usual dosage. And those on steroids or those who were on pre-admission, so the total dose was more than 80 units, you will have to follow the resistant column. You can see here the dosage will be, supplemental dosage will be more compared to the other 2 columns. So like that, you have to calculate upon the supplemental dosages also. So if the dose adjustment of supplemental columns, how to adjust the column? The fasting and the pre-meal are more than 140 and no hypoglycemia recorded. The patient was on sensitive column, you can move that from the sensitive to the usual column. If the patient was already on usual column, you have to change the supplemental column scale from usual to the resistant column. And the patient develops hypoglycemia, blood glucose less than 70, you can see here, if the patient was already on resistant column, higher dosages he was getting, you will have to come down to the usual column. If the patient was already on usual column, you will have to come down to the sensitive column. So these are the supplemental dose adjustments of insulin. So coming back to our case, maybe it would have gone out of your mind. So the patient was a CLD with a cirrhosis liver, child C, and some AKA was also there with AKA or AKA and CKD with creatinine 2.1. Again, he was started on basal bolus with regular and NPH. NPH initially it was, you can see here from the initial days. This was 1 week after admission. You can see here there are many hyperglycemia values are there, definitely peakings are there. And 1 week again, 1 week later, after giving corrections and all, you can see here the values are below 200. You can see here below 200 and peakings above 200 as the patient was having critically ill. Below 200 was fine. And you can see no hypoglycemia also. You can see here 70. No, now it's going below 70 also. And here no supplemental doses were also not required. But another thing you can see here at discharge, he was discharged with a regular insulin of 50, 34, and 24 and NPH of 36 and 8. You can see a high dosage of insulin. It is quite commonly seen when patients with severe cirrhosis liver or severe CKD on dialysis and all, the insulin resistance is pretty high in these patients, and the dosage of insulin requirements also go high like this. So there's a type of bolus insulin matter in the hospital, analog versus human insulin. So as we have seen, there are analog insulin and human insulin. So if giving analog rather than human insulin, better. So this was one study which looked into the comparison of analog versus human bolus insulin. So you can see here analog bolus insulin was associated with a lower mortality because the duration of action is a little bit less compared to the usual, or is less compared to the regular insulin, and so that decreases the risk for hypoglycemia also. So lower mortality, shorter length of hospital stay, and modestly better glycemic control. You can see here 231 versus 239. But definitely the mortality was statistically significant, 4% versus 9%. And the length of stay also was statistically significant, 5.3 versus 6.4. So it was less with the analog insulin. So if possible, the patient, again, the drawback could be the cost. They definitely diabetic foot management itself comes with a financial burden for the patient. So the affordability will definitely come as a hindrance. And I again searched out whether intensive versus conventional glycemic control for treating diabetic foot ulcer, what will the wound changes? Whether the wound is benefited or the wound changes was searched into. A Cochrane review was searched into. But you can see here that this was in 2016. This review failed to find any completed randomized clinical trial with the results. So there are no RCTs looking into the intensive versus conventional on the foot aspects or the foot changes, foot size, foot deterioration. So all those factors. So there are no studies or no RCTs on that. Observation rates will be there, but no RCTs on that. And I think PG in collaboration with other centers are planning up for a similar study. Perioperative consideration, the last part. There currently exists no evidence-based guideline detecting when to cancel surgery due to hyperglycemia. We all know that many a time from the anesthetic side, the surgeons feel the pressure of cancelling the surgery because of the HbA1c. But currently, no evidence-based guideline detecting when to cancel surgery. But if the patient is on, definitely if patient is admitted with the DK or HSS, you will have to withhold the elective surgery emergency. Then with the managed DK and HSS, you will have to proceed with emergency surgery. And then the Yale Hospital recommended cancellation when the blood glucose levels are more than 400. And the Boston Medical Center suggested when the blood glucose is more than 500, surgeries can be cancelled. So these are all not evidence-based, but different center protocols. The patient is undergoing for major surgery, then GIK infusion or the glucose, insulin, potassium infusion can be considered. Here, glucose is supplied in the form of dextrose for the 5% dextrose. You can see here 500 ml, 5% dextrose, or even 10% dextrose can be taken. The insulin dose to be added in this, the glucose insulin. So insulin dose added should be like 0.3 unit per gram glucose. You can see here 5% dextrose means 5 grams in 100 ml. So 25 grams in 500 ml. So 25 into 0.3 is 7.5. I rounded it to 8 units of short acting of the regular human insulin should be added. And 10 millimoles of potassium or even 10 or even 20, there is 1 ampule of 7.5% KCl can be added. The infusion is started at 8 to 9 a.m. on the day of surgery. And the infusion is started at a rate of 100 ml per hour. And the dose can be, the infusion rate can be adjusted according to the blood glucose. It is measured hourly or 2 hourly. And accordingly, you can see here, you can increase or even decrease the rate of infusion of GIK. Then the perioperative care, again, the target to keep it between 140 to 180, discontinue OAD and non-insulin injectables like the GLP-1s. Then a reduction of insulin given the evening before surgery by 25%, that can be considered. So that is that if, say, for example, tomorrow is a surgery, the previous night or the today night insulin dosage, if it is well controlled, the insulin dosage can come down by 25%. And on the day of surgery, you can give the half of the NPH or the dose of dose which is the patient receiving. If it was NPH, you can give the 50% dose of that on the morning of surgery, or 80% if the patient was on long-acting analog, like say for example glargine and all. So the 80% of the basal dose which he was getting can be given on the morning of surgery, and the blood glucose can be monitored at least every 4 to 6 hours, and even if required, supplemental doses can be given. Minor procedures, type 1 diabetes, we can continue with the insulin dosing, like say for example scraping of the callus and all. You can continue with that same dosing. Type 2 diabetes, if the patient is on insulin, continue with the same dosage for minor procedures. The patient is not on insulin, monitor the glucose 2 hourly, and it is well controlled, I'm telling. And OAD can be started with the first meal after the surgery. This is only for minor surgical procedures. So the transition from the hospital to the ambulatory setting, medical reconciliation and structured discharge communication should be there. Medications must be checked for, insulin dosage must be checked for, Medication changes must be informed to the caretakers who are taking care of the patient. What are changes are there? New medication, some medication is removed. Definitely it should be conveyed properly. And scheduled follow-up appointments are also necessary to prevent readmission for hyperglycemia. So to conclude, the take-home message will be glycemic control in diabetic foot patient is important for a favorable overall outcome. Insulin holds the key in glycemic control for in-hospital management, and the sliding scale of insulin should not be used especially in hospital settings. Comorbidities also holds a key in glycemic management in diabetic foot patients. Thank you so much for your patient listening.
All right. Yeah. Thank you, Dr. Prem, and congratulations, because I think you did the tightrope walking of making this very complex subject and breaking it into smaller pieces and quite understandable to everybody, very nicely and very lucidly. I really enjoyed listening to you. Thank you very much.
Thank you.
Should we first take the questions and then can sum it up?
Yeah,
I think that will be better. Yeah, somebody wants to know, they just want you to repeat about how to calculate total daily dose.
Total daily dose, as you can see, if you're starting on the basal bolus insulin, it can vary from 0.2 to 0.5 units per kilogram. So if the patient is elderly or the patient has a renal dysfunction or CKD with EGFR less than 30 and all, or other comorbid illnesses, you can start with a dose of 0.2 to 0.3 units per kilogram. If no comorbidities and the blood glucose value is between 140 to 200, you can start with a dosage of 0.4 units per kilogram of body weight per day. And if the blood glucose is more than 200, you can even start with a 0.5 unit per kilogram per day total daily dosage, which can be split into 50% basal and 50% will be given as 3 times of the prandial dosage if the patient is taking oral diet.
Okay, and that answers the first question. The second one would be, this is from Dr. Balveer Singh. He wants to know, when surgery of diabetic foot having gangrene changes, what should the blood sugar level be to be maintained? He just wants to know what are probably the target or the goals for maintenance in patients who have gangrene.
Yeah, so nothing specially for gangrene as such. The patient is having, as said, critically ill and admitted, definitely will be giving infusion. And on infusion, our target will be to keep it between 140 to 180. And as said, if the patient is not critically ill, the gangrene is like, say, for example, you will see sometimes toe gangrene, dry gangrene, or we are waiting for the ANM to get autolysis. So in that cases, I said, the patient is admitted in the hospital, definitely the fasting should be kept, no other comorbidities, fasting should be kept as tight as possible, I would say put it around 100. And the pre-meal targets that mostly we'll look into should be less than 140.
Okay, thank you. A patient of thalassemia having diabetes mellitus and sugar more than 200, so how to treat such patient? Now, Dr. Babil, I think it's a bit difficult for me to ask him to, Dr. Narayanan, to ask to answer, because is this patient also suffering from foot problems?
Yeah, because it is incomplete data, Dr. Babil.
Yeah, incomplete data.
Yeah. So it is a vague etc. Because we need to know the age of the patient, what are the comorbidities, what is the status of the thalassemia, because we will know that HbA1c will not be reliable. So we'll have to know how many years diabetic the patient is. So multiple things are there, Dr. Babil. Sorry, I couldn't answer that.
Yeah, correct. So it will be difficult for us to tell like that. Agree. Suppose the patient is on insulin subcutaneous. When are you likely to shift them onto OADs?
So that again depends on what is the status of the foot of the patient. So here we are dealing with mainly with the diabetic foot of the patient. So if the patient has no other comorbidities, or there is a renal part is fine, or the patient does not have any heart failure or any other things, we will continue with insulin until the foot part is completely stabilized or the wound is completely healed, insulin should be continued after that. The patient has other comorbidities like say for CKD and all, then definitely, or even other major organ failure as seen in our patient, the patient discussed, like the cirrhosis liver, etc. So then in that case, definitely you'll have to continue on insulin with targeting to avoid hypoglycemia also.
Is insulin a must in the plan of management or in these patients?
Yes. So
can you do without insulin?
Can do without means so in that case, I have already shown you a slide where the ulcer characteristics of the patients. Sometimes we may see patients with ulcer of 2 weeks or even 3 weeks duration, but no other systemic features or then no other comorbid illnesses. I mean, you are managing, you have just debrided and a small wound is no bone involvement. So in that case, you are just debrided in the OPD wise and you have asked the patient to offloading. The patient was not doing offloading, no advice to do the offloading. The A1C is not very high, like say for put it around 8.5 to 9%, around in that range. In that case, and I would look into the OAD, and if the OADs were inappropriate, I would suggest spiking up the OAD in controlling the glycemia rather than going on to the insulin. If the patient is having high A1C with no comorbidities, like say for A1C is more than 10% or even 11%, roughly I would put it. In that cases, definitely or I would even it is not critically ill. You can do one thing. You can start either with the premix insulin. The patient, depending on the A1C values, you can start with the premix insulin one dosage plus titrating the OADs, or you can start with the basal insulin plus titration of OADs also. You can. So it is all individualized. It varies from patient to patient.
Yeah. Let me rephrase that question.
Yeah.
Will insulin bring about a better or earlier healing of the wound ulcers? Do we have evidence regarding that?
No, so that's what I think. Even I searched for RCTs for the intensive control versus conventional control, but there are still now or till today there are no RCTs on that. And as again I said during the lecture, PGI is planning for one study, similar study, to look at the wound characteristic with the intensive insulin glycemic control, whether there are any advantage or disadvantage with that. We don't have any RCTs so far.
Yeah, it was said that because insulin happens to be an anabolic hormone,
yes,
so it's likely to improve the wound or in general.
Exactly, because as even
the patient might be better.
Correct.
Without that.
General improvement, that is the patient was having weight loss, and in that case, definitely the general improvement definitely will be there. But as per the wound characteristic, we are yet to have any randomized clinical trial on that. We have many observations and hypotheses, speculations, postulations, but if you ask me about an RCT, we don't have any on RCT.
I know we do not have RCTs for most of them.
Correct.
So I think we have been trying to extrapolate it from other surgeries and then applying it to the foot.
Correct.
Or other say similar diseases to foot. Unfortunately, we do not have any RCTs.
Yes, because the biggest hazard will be the hurdle will be the ethical consideration.
True.
Yeah.
Ethical considerations would give rise to a lot of problems.
That will be an issue.
Yes, it is. Yes. Yes, many of them have congratulated you on your lucid presentation.
Thank you. I hope it was useful.
Yes, it was a very good one, and I concur with them. And well, I think we have covered much of the questions that have come in. Somebody had just said protein, so I don't know what they mean by that. But I think
protein is definitely important. We know that many of the patients who are coming, they may have even hypoalbuminemia is one of the important feature, or hypoalbuminemia can lead on to decreased wound healing, or even studies have predicted as given as a predictor for amputations also. Yes, so protein supplementation will be required. So as usual, usually it is a 0.8 to 1 gram per kilogram body weight is a usual normal requirement of the protein. The patient is having is in a catabolic state and the renal functions are normal, then even you can go up to 1.2 gram per kilogram body weight. But if the patient is having end-stage renal disease and on dialysis, Even higher dosage can be given because patient is already on dialysis and the patient is in catabolic state. You can go up to 1 to 1.5 gram per kilogram body weight protein can also be, definitely it can be supplemented.
Okay. Well, I think they asked this question probably inadequately before this. They corrected the question regarding the gangrenous changes. They say that there is septicemia, so requires surgery for control of sepsis.
Yes.
So whether we should wait for blood sugars to control first before we take them.
So that was the thing I was telling you that the tug between the surgeon and anesthetist that can happen. So sepsis and we'll have to wait.
We'll have to 22 situation.
Correct. So the patient is the risk benefit ratio and the patient is in severe sepsis and there is life threatening. Then definitely you can start with a fluid support and insulin IV insulin infusion. Along with that, you can proceed with the surgery. If it is an elective surgery, you wait for the sugar to get glycemic status to get controlled. Or if the patient is in DK or HSS also, you have to wait for the glycemic status to be controlled for elective surgery. Emergency, definitely you have to proceed. Say one patient was going on the road, the patient had a trauma, he was diabetic, he was not taking medication and he is having hyperglycemia for more than 400 and he has a head injury. You will have to proceed with the surgery. You don't have any choice. So in that case, you will have to proceed.
I think precision medicine will come in. It will come handy at that time.
Correct.
So I should just sum it up at the end.
Sure.
Yes, diabetic foot and hyperglycemia is actually a very challenging job because we need to balance between hypo and hyperglycemia, because we know that inpatient or even for that matter outpatient hypoglycemia increases both morbidity and mortality, and it does not certainly help wound healing in our patients. So there are so many different societies which have given us different kinds of targets and goals. But in general, if you look at it, if you combine all of them, the reasonable figure which one must remember in clinical practice would be, so you need to have the blood sugars between 140 and 180 and certainly do not exceed beyond 180. Though ACP says you can go beyond 200, up to 200, up to 200. So this is the goal that we need to remember, and I just simplified it because of various societies say various figures.
Yeah.
And as I told you, yes, societies and guidelines are good, all right, fine, but at the end of the day, every patient is different. So you need to cater or tailor your management to every patient. And that's precisely what we call as precision medicine.
Definitely.
And this is how it has to be. All right. So that it plays a very huge role. And then, yes, there is no sliding scale anymore. Sliding scale is going to not be it's a roller coaster ride of a very unpleasant variety. So we do not want to venture into it. So we need to use correction doses. You need to calculate TDD and then correction doses, and then you will have to tell your nursing staff to do the needful.
Correct.
So that is another one important point which we need to remember. Of course, you have now different kinds of insulins. You have designer insulins, you have ultra short acting to the long acting ones, with action of which will last for more than 1 day, more than 24 hours. But then when we use them in our patients, we need to be a little sensitive to the cost effectiveness of these, because many of our patients spend from their own pockets, and as it is, diabetic foot is associated with huge expenses. So we need to be very, very sensitive about that. However, if you think it is required in a particular patient who has, say, little diabetes or something like that, or if you want to bring down the sugars very fast and make them ready for, as he said, septicemic surgery or something like that, maybe you can use these expensive insulins. And yes, last but not the least, the most important one is that lack of good evidence. So we do not have any evidence regarding what kind of insulin we should use, or for that matter, when do we use, when we do not use, whether we should use insulin at all, and whether we can use OADs in their place, etc. So lack of evidence makes us, it doesn't make us we do not unite in our fight against diabetic foot so far as hyperglycemia and its management is concerned. So it seems to be a bit of a haphazard thing occurring right now. And then there is an added confusion, which I forgot to ask you about your opinion, that many of the OADs have not found to be very favorable. Though we have CVOT trials for GLP-1 receptor agonists and SGOTs and so on and so forth, so many drugs, unfortunately, they have not studied it in food, and when they have studied, they do not have very good evidence for it. For example, with canagliflozin,
Correct.
we had a rude shock in the form of increased amputation.
Correct.
Though subsequent meta-analysis have said that SGLT2 inhibitors can be continued and then they can be used and then there is no real increase in the amputation rate, etc. But still we carry that, what should I say, injury. Correct. Or a blow to our mind by that evidence. So we are not very eager to use SGLT2 inhibitors in these patients. So I think I agree. You agree with me on this, Dr. Prem?
Yeah, yes, definitely.
So yes, go ahead, use OADs, use insulins, but use them very judiciously and be sensitive to the patient's to the expenses. That's about it. Correct. So Dr. Prem Narayanan, I think I've summed up what you have said, and then I thank you wholeheartedly, and thank you DFSI for giving us this wonderful opportunity to discuss and debate about diabetic foot and hyperglycemia and its management. Thank you very much.
Thank you, Dr. Arti, for the nice conclusion, and hope to meet you soon again. And thank you, DFSA, for this opportunity to deliver the lecture. And thanks to all the audience for joining our program. Thank you. Bye.
Thank you, audience. Too. Thank you.